Thanks, Graham. It's always really good to follow someone as enthusiastic and passionate as Trish, because I think what she brings to urology and all the way down to her individual patients is a real caring approach and someone who's passionate about what they do. And I think that's really the key to providing good care and good value. The things I'm passionate about is New Zealand and our healthcare system. And I'm very comfortable talking about the public system and really making that work, and also understanding that in New Zealand we have approximately 40% of our healthcare delivery in urology in the private sector and around 60% in public. And my goal is to improve the quality of care in both systems, and the process of doing that is what I want to talk about today. But first I want to congratulate Graham and Mark, because I think they have grown this group into a very professional organisation, and I think there's a lot of debt owed to them. And I turn to the back page of the brochure, and to have a very clear vision of what this entity does, they really live that, and I think they do a very good job. So thank you very much for that from a patient's perspective. And it does help us quite a bit to have a very good functioning advocacy body who is well thought of. So I congratulate everyone for turning up here today on a Sunday to listen to this, and it's really good to see the large number of women in the audience as well as men, so well done to you guys. What I want to do is just talk about what the Urological Society as an entity is trying to do to improve the quality of care. So I apologise, this isn't really about flash toys or new ways of doing things, but it's about ways of doing what we do better, and it's understanding systems. So the principles of that in our public hospital system is really to get the best quality care undertaken at a speedy time in a cheap environment. And that's actually something New Zealand is very good at doing. We're called fast followers. We're generally not leaders in all areas, but what we try and do is pick something up and make it work better for our system. In urology, what we've tried to do over the last 5 years is have a process of measurement, reporting, and improving. Those three things linking together. And what I want to do is present stuff on what's called a process measure, that's how you do something. An outcome measure, that's what the outcome is of what you've done. And lastly, a little bit about what's being done about costs, because costs are really important, not only for the government. Unfortunately, health can cost a lot of money, and we're on a trajectory where we're spending more and not getting any more benefit from it, and you can continue to do that. So what we need to do is work out how can we do things a little bit cheaper. But also in the private sector, things are costing a whole lot more and it's not sustainable. So somehow there needs to be a gap, and there's a variation in what people are charging, and somehow we've got to work out how do we minimise some of those things, because financial pressure is a huge burden for someone with a cancer diagnosis. And lastly, how are we getting individuals aware of what they are in relation to others, so a personal report. So to talk a little bit about a process measure, that is how we are doing things. And there's a lot of information we talk about nowadays, big data, artificial intelligence, a lot of stuff I actually don't fully understand, and luckily I have a teenager who can do my cell phone when I get it from the shop, and I take it along and I say, can you fix that for me so it works? And a little bit of this stuff is like that, not all of it. When you go into hospital, there is a little bit of information that's collected to you, that's collected on you, that's put into the system. And that's things like your date of birth, your address, your GP, your date of hospital admission, your diagnosis, your operation, your admission date, and your discharge date, for example. And there's actually a lot more, and that's called big data. It's free, it's available, and if you have a clever adolescent and a computer, they can analyse it. And they can sometimes give you information about that, which you would have taken quite a long time to do if you had to set it up in parallel and pay someone to do it. And increasingly, this data is available. So it's a simple measure, but there is a question of the accuracy. And what we have tried to do is link up with a group that are showing us how to use this information to improve the quality of care. So they're called process measurements, it's big data, and it's generally called routinely collected information. And the Health Roundtable is a body that actually pulls all that together for Australia and New Zealand and tries to give us reports to say, can you do it better by recognising, is Auckland doing something different to Dunedin, doing something different to Wellington based on the big numbers? And what we've done is we've taken that information and say, how can we make it something that simple doctors could understand, that we want to actually look at? Because most of us are interested in talking about a patient in a room dealing with a problem, and when you talk about this stuff, your eyes glaze over and you try and think about something else. So you've got to make it relevant to the clinicians. And the goal of this was to have reports from the New Zealand hospitals in urology units on relevant operations that gave us information that may be useful for us to say who are doing things more efficiently and how can we learn by that, with an overall goal of saving money, reducing variation and improving outcomes. This is a sort of report that you get given if you log into one of these things. And I'll briefly walk through it. What this report is a whole urology unit's activity, everything they do for a year. A red bar means are you getting worse, and a green bar means are you getting better over 12 months. The triangle, or diamond, is where you are in relation to a percentage. And for us in Canterbury, 1% difference is $50,000 a year of government funding to our unit. So all of a sudden 10% becomes $500,000 difference of a saving. Now we are 3% of the health budget of Canterbury DHB. So if you scale things up, there's quite a lot of potential saving of just looking at information and saying, hold on, why is Canterbury down here and possibly Auckland a bit higher, Wellington a bit higher? This is Australian and New Zealand units that are deemed to be much the same population doing much the same stuff. But doctors look at this and they say this is a measure of something they call relative stay index. So what does that mean? I don't actually know what that means. I personally do, but to try and explain that to someone else is quite complex. It's not a defined meaning. So what we've done with the DHB, with the Urology Society, with the Health Roundtable, we've said give us a couple of straight operations, just the operations, not the whole unit, because we know a radical prostatectomy is much the same around the country, and give us that data in very simple forms, and then we'll try and show it to the clinical directors 6 monthly for 2 years and see if that makes a bit of a difference. It's not a particularly complicated thing. It's like a bit of a report card. It costs some money, so we've had to pay for that from the Urology Society, and it aims to look at, does this improve length of stay? Does it reduce cost for the government? It's a novel process, but at least we're one step ahead of the game. And these are the first reports that have come out. So I just want to walk through what they mean. So this is laparoscopic prostatectomy. Each of these diamonds are a different unit within the hospitals within the country. And this is the length of stay. You can see there's a group down here that are much the same, and then there's some that are a bit higher. I've taken the names of the hospitals off because it's actually confidential information back to them. This is not a public report card, but the aim is for us to look at it and say, why are these guys up here? Should they be able to shift it down? We've also got a British equivalent. We've flogged some data from the UK and said, what are the UK people doing? And we've got a New Zealand equivalent. Then we've got open radical prostatectomy, the most common operation for prostate cancer in our public hospital system. Along with this, we've also got total numbers of cases. One of the things that's been talked about is, should all cases go to central areas? Should they all be centred to Wellington, Auckland and Christchurch and Hamilton? More people there, better surgery is done when there's more people. This, in fact, shows most of the small places have quite short lengths of stay. So it's not really supporting that, but it's useful to have that information. These places and these places might be able to get a bit better, and as you can see, we're all pretty much better than the UK median. The next is a slightly complicated measure, because if you can show that you have a percentage of patients who are staying a lot longer than they should be, more than 10%, sometimes the quality of the surgery is not as good, because they should actually go home at much the same time, and if quite a few stay longer, so there's 3 of them within the DHBs in New Zealand that have a percentage length of stay that's a bit longer than you would expect, and it questions whether the quality is right. All this is asking a question, not giving an answer. The next is a slightly complicated graph, but this is around kidney removal, doing it laparoscopically or open. And there's some places that do it all laparoscopically, and there's some places that do it all open. And we can't shift patients from one DHB to another. So there's a variation, and it asks a question. Should this be the outcome we want, or should we all go back to what is the New Zealand and British median, which says this is how we should do the surgery? So it's just an idea of looking at process measures to improve cost and quality. So we've done our first lot. The second lot's due to go out soon. The majority of units are actually performing very well relative to the British units, and we're lucky to have an international benchmark. But some units can reduce length of stay. and it's discussed with other CDs because the report that we get to the clinical directors is all identified. So you know who the good ones are, and you know who the longer stay ones are, and there may be good reason for that. But at least there's a conversation that can be held. A few units have a high percentage long stay, which calls onto the quality of it. Nephrectomies are performed laparoscopically much lower in some units. And interestingly, laparoscopic radical prostatectomy doesn't have a lot of benefit when you look at length of stay, and that's its main benefit. So should we be doing something that's twice the cost and the same outcome in our public hospital system when it's not delivering the goal? It's just a question that's being asked. This is not trying to say don't do it, just ask the question. Second thing is outcomes. I've talked a bit about outcomes before. It's a separate thing and much harder to measure. How well did the patient do following their radical prostatectomy? Not just how long was their hospital stay. There's a little bit of benefit in that. So we're grateful to a group I'm involved with, which is data collection, and the Movember Foundation that are funding it, but the goal is to recruit all men with a new diagnosis of prostate cancer, all of public, all of private. This entity is chartered with collecting the data, and there's a steering committee that's chartered to look at the best use of the data, and there's a report back to each individual clinician as to how they're doing. It takes 12 months of data collection and a minimum of 10 cases to get a report. So it's not going to be something that happens immediately, and all this takes time. So there is a due process where anyone can apply to the Prostate Cancer Registry. PCFNZ, for example, could say, we would like to know what percentage of patients diagnosed are Maori men, just as a part of the entity. Barry may be very interested in that, and we've got that data available. But there's a process of applying for information, and that has to go past a committee to say, is this confidential information okay to be let in that arena? So you've got a process of gathering the information and making it available. And the goal is to improve access to and quality of care. So where are we at with that? As we know, 3,000 men are diagnosed with prostate cancer in New Zealand. It's the commonest cancer, but the biggest thing, it has the highest number of survivors, because men actually live quite a long time with prostate cancer. And they generally live with the consequences of that diagnosis and treatment. So there are quite a few quality of life effects. Prostate Cancer Outcomes Registry, New Zealand is a part of a group which is the Australian and New Zealand group. We're benchmarked against the Australians and New Zealanders. All states of Australia are the same. And we're also part of a global entity looking at global international benchmarking to say what should our results be in relation to a very big group. And the goal of this is to have a very agreed set of data that you're collecting. So we basically flogged a bit of intellectual property and had it funded, and now we're trying to implement it. So the New Zealand activity is to recruit all of the patients within DHBs and the private clinics to collect the data centrally and to subsequently store that data in the Monash registry, bring it back to New Zealand on a daily basis where it's also stored at home in the server somewhere, which to me is like a screen which is behind a locked wall. I have no idea what a server does or is, but the data is apparently there. Someone can look at it. I don't do any of that stuff. And the goal is to change practice through a quality improvement program, to give feedback to the clinicians and say, is there benefit or not? Who's doing better and how do we get better at it? And we also contribute data to the Australia and New Zealand and Global Registry. So this has now been run for about 18 months, and where are we at with things? Implementing a registry where there's patient information that's identified, that's going to Australia, in a current environment where you've got people with clipboards and fluoro vests and privacy as part of their name is not easy to do, especially if it's funded by a charity and it's funded from outside of New Zealand. So there's a lot of challenges of implementing this in an environment where our healthcare is really quite disjointed. However, we've currently got approval to collect data from over 70% of the population, and the data collection is around 50%, and we have a 3-year goal of getting national coverage, and we're about 18 months into that. From the first 1,000 men who are recruited in, we have, from the initial cut of data, a large population who are non-Maori. We have a group of men who are mainly got localised disease. We have a group of men who mainly have surgery, but a large number on active surveillance, and a number who have had hormone therapy in conjunction with radiation and radiation treatment. So we've got some initial cut of data from the first 1,000 men. That's where we're at with the outcomes registry. Now the financial stuff. Financial data is interesting. the Australians have had this recently published, and it's looking at their healthcare system, but our goal is to have a blueprint of how do we look at financial costs in our New Zealand system, because we have much the same issues here, but there's no mechanism of making that visible. So the College of Surgeons and Medibank, which is the third biggest provider of private healthcare in Australia, got together and gave a surgical variance report for the costs of treatment of surgical management, and urology was one of the reports, and radical prostatectomy was one of the first ones off the rank. So what they do with this is, again, it's big data. They put in two numbers which you apply for if you have an operation and get funding for it. They then run that through their database through all of Australia, and then they set out a spreadsheet of where the cost was for that operation, because they're paying the bill and they know the code, so they know the costs. And they publish this in the public media. So this graph, and I only took one graph out of it, was the out-of-pocket expense from the patient for the surgeon's operating bill. Because if you do an operation in private, there's a bill that goes to the surgeon, there's a bill that goes to the anaesthetist, there's a bit of stuff for the hospital, because apparently it takes money to put someone through a hospital, and there's a bit of stuff for equipment or kit, if you use equipment and kit. But this is just the variation in the individual patient cost for the surgeon bill. So this is the out-of-pocket costs that is different on average by state of Australia. And these dots represent the individual surgeon's bill to the patient that shows variation. So this was then put in the public arena, and of course, imagine the media love this sort of stuff. One person, the average was $20,000 more than their insurance covered. It's the same insurance policy. So all of a sudden, it just showed such a variation, and it asks the question, why would that be the case? All this is meant to do is to have a conversation to try and keep things back to a more acceptable level. But in fact, the majority were in, I think the median was $2,500 on top of what the insurance company paid. So I suppose if we sat back and looked at the three measurements we've got available, we've got process information, how are we doing it? We've got outcome information, and we have some opportunities to look at financial information directly relevant to our DHBs still overall, not this part, because all DHB surgeons are salaried, so they're the same cost across the board. But it does ask the question of how are we giving feedback to improve the quality of care, and for what some of the visions of this is to certainly reduce patients' suffering, and financial suffering is an important part. And USANZ hopes to pull those three reports together, make it individualised, and make that feedback available to the individual surgeon to know where they fit for those things, for those procedures. So in summary, Graham said, make this talk interesting. And I thought, Jesus, how do I do that? And because I said it's not really that interesting. It's numbers and it's general stuff, and it's not sort of a flash machine. And I was lucky enough to go to the Nepalese urology meeting. Everyone says, oh, geez, that's a junket. And that's the bit on the side, which I fully paid for myself. But the reason for the Nepalese meeting was around the Asian Society and the Urology Association of New Zealand and Australia being a conduit for the world, for the Asian Society. So we've now got the meeting for the UAA international meeting being held in Sydney under the USANZ banner, because USANZ as a political and a sort of physician-based forum sees Asia as a very prominent growth area, and the conduit through Asia is where Australia and New Zealand are seen as acting, and so we were linking with them. Somewhat related to this, which was our Sherpa, who managed to ferry Hamish, my GP next door neighbour, and myself to the top of the Annapurna Pass about 2 weeks ago, 5,400 metres, which is slightly chilly, I'd have to say. But it was an experience, and it made it more interesting. Thank you.